So we are going to discuss the critical case station esophageal varices and hematemesis. So 45-year-old man admitted to hospital with a history of hematemesis, on examination jaundice and ascites, post medical history of alcohol abuse. After a second episode of hematemesis he becomes confused, decreased BP, increased heart rate, shock. Lab results are available. Chronic alcoholic 3 times of hematemesis, decreased blood pressure and increased heart rate. And you are a surgical ST3 on call in a district general hospital with no gastroenterology services and have been asked to attend the A&E to receive a patient who had a profuse hematemesis and was becoming hemodynamically unstable. The patient is known to consume excessive amounts of alcohol and make use of her substance, other substances as well. On arrival to emergency, you find a patient with a BP 170, heart rate 120, respiratory rate 30, temperature 37.4 degrees centigrade, oxygen saturation 91%. So what are your concerns regarding this patient? So ongoing bleeding resulting in hypovolemia as a patient has cirrhosis and clotting abnormalities, likelihood of complications such as hepatic NCAF, AKI, and hepatorenal syndrome. So what are your differentials? Bleeding esophageal varices or due to portal hypertension caused by cirrhotic liver, Milorvis, tear, Boerhaave syndrome, and bleeding peptic ulcer can be the causes. How will you manage this? So since it's a critically ill patient, so I will manage this patient according to Suktis protocol A, B, C, D, E. Active resuscitation, reduction of portal venous hypertension, and measured to avoid hepatic NCAF. High flow oxygen venous access immediately. Cross matching 2 to 4 units of blood after discussing with hematologist. Fresh blood transfusion, FFP, platelets, and consultation with hematologist. Close monitoring pulse, blood pressure, hourly urine output, center venous pressure monitoring. Assessment of coagulation status, prothrombin time, platelet count, and INR. Control of bleeding, tamponade, Minnesota. Okay, so I will first of all I will start from if I'm going for the hemorrhage control is first of all I will do correction of PTINR, then I will go for terlipressin and beta blockers. Yes, I will go for vasopressin or terlipressin, octreotide, and beta blockers, and then I will do urgent endoscopy. This step Minnesota tube is a lateral choice. So first in algorithm is your pharmacological, and then you go for urgent upper GI endoscopy, where you will do the sclerotherapy or bending or injection sclerotherapy or whatever. So endoscopic band ligation not more than 6 bends per sessions, and then if it's not helping and not stopping, then we can go for Manitoba tube. So what are the rules of endoscopy or endoscopic bleeding esophageal varices? So this is the main weapon for the esophageal varices, diagnostic and therapeutic. So you can do injection of sclerosing agent and adrenaline to stop the bleeding site. Band ligation can be done, coagulation, apply hemostatic clips, and apply hemostatic spray. What could be the cause of thrombocytopenia in this case? So hypersplenism, TIC, hemodilation, chronic low platelet production, decreased hepatic production of thrombopoietin. So thrombocytopenia, because this patient is cirrhotic, so he has enlarged spleen, so there can be hypersplenism, and there can be DIC, hemodilation because of the over transfusion of the fluids, and chronic low platelet production because of the toxins, and decreased hepatic production of thrombopoietin because of the cirrhosis. So these can be the causes of low thrombocytopenia. What are the indications for platelet transfusion? Ongoing coagulopathy with continued bleeding is a part of massive blood transfusion after consultation with hematologist. So you have to give it in 1:1:1. FAPs, packed blood cell, and platelets. Which varices are usually bleeding? Varices in the submucosa of the lower esophagus are the common source of major bleeding. Blood Findings in alcoholic patients. Features of full blood count to suggest alcoholic abuse. So low platelets due to toxic effect on bone marrow. Impaired hematopoiesis also affect RBCs and WBCs. Raised mean corpuscular MCV. Anemia and megaloblastic hemolytic anemia. Elevated liver enzymes. So in alcoholics we have megaloblastic anemia because of the deficiency of folate and vitamin B12. So elevated liver enzymes, increased PTNR, GGT, AST, ALT, and ferritin. What is the pathogenesis of portal hypertension and chronic alcoholism? So pathogenesis for portal hypertension and chronic alcoholism is because of cirrhosis result in chronic liver disease and is characterized by liver cell damage, fibrosis, and nodular regeneration. The fibrosis obstruct portal veins, venous return, and portal hypertension develops. In cirrhosis, portal vascular resistance is increased. As we know, pressure is equal to flow into resistance, so proportionality pressure will increase. Surgical treatment options for therapeutic maneuvers to reduce portal venous pressure. So there will be portal systemic shunts. First of all, your pharmacological treatment is like give him beta blockers to decrease the pressure, and then if it's not working, then we can go for portosystemic shunts like a lino-renal. You join the splenic vein to the renal vein, usually the left renal vein, and if it's not, there are other choices like mesocaval superior mesenteric vein is to the atrial vena cava, or you can also go for TIPS. Metallic stent is inserted through the transjugular route using a guide wire passed through the hepatic vein to the intrahepatic branches of the portal vein. So you directly connects the portal vein to the hepatic veins in this portal vein. So staple esophageal transaction. The gastric vein and short gastric veins are ligated, and the distal esophagus is transected, and reanastomosis is done just over the cordia using a stapler gun. So here we have the orthotopic. So the definitive treatment is your liver transplantation. This is the definitive treatment. So here is the, we will come to the diagram later on. So what is TIPS? Now they're asking about TIPS, and we have a long way to go. Okay, we can do it. So what is TIPS? So the transjugular intrahepatic portosystemic shunts. TIPS stand for transjugular intrahepatic portosystemic shunts, a procedure for the complication related to liver disease to decrease the. So actually this is not a definitive treatment. This will just buy you some time to go for transplant or other definitive procedure. So purpose is TIPS is used to reduce high blood pressure in the portal vein called portal hypertension, which often occurs in the context of liver cirrhosis. So this is your hepatic veins. So you join the hepatic veins directly to the portal vein. So being this cirrhotic. During the TIPS procedure, a radiologist inserts a stent through the jugular vein and the neck and directs it into the liver. The stent creates a small passageway inside the liver, allowing blood to flow directly from the portal vein to the hepatic veins. This bypasses the liver, the damaged liver, to reduce the pressure in the portal system. So what are the implications of TIPS? When there is ascites and there is recurrent bleeding, and you buy a time for going for transplant. So when fluid accumulates in the abdomen and cannot be managed with dietary sodium restriction and diuretics, TIPS may be considered. It can also help with a condition called hepatic hydrothorax, where ascites crosses the diaphragm muscle and fills the space around the lung pre-refusion. Bleeding varices. TIPS is often needed when bleeding from the swollen veins, varices in the esophagus, stomach, rectum, and elsewhere cannot be controlled with endoscopic treatment. So when there is recurrent bleeding and it cannot be controlled with the endoscopic management, so you go for TIPS, and it's not the definitive, just buy your time to prepare for transplant. And how does alcohol cause liver cirrhosis? So change in lipid metabolism. Alcohol causes change in lipid metabolism. So lipid accumulation occurs in the hepatocytes. This leads to hepatocyte damage because it will produce reactive oxygen species and cytokines. This induces inflammation and causes liver cell damage, fibrosis, and nodular regeneration. Over time, the process turns normal liver into cirrhotic liver. What is the cause of confusion in this patient? Hepatic and cough, hepatic encephalopathy. Okay, so they can ask also that how ethanol or alcohol metabolism occurs. So there are two steps. First, the alcohol dehydrogenase converts the ethanol into uh, the aldehyde, and then the aldehyde converts the um, no, the aldehyde dehydrogenase converts the aldehyde into acetic acid. So acetic acid is used for the production of fats, so it can cause over accumulation of the fats in the hepatocytes, and it can lead to damage. So two steps: ethanol into aldehyde through the alcohol dehydrogenase, and aldehyde through aldehyde dehydrogenase into acetic acid. So this is simple. What are the hepatic changes as a consequence of excessive alcohol consumption? So hepatic steatosis, fatty changes, enhanced lipid synthesis, as I said, decreased hepatic lipid metabolism, decreased export of very low density lipoproteins, accumulation with the hepatocytes, converting the liver from a lipid burning to a lipid storing organ. So what will this hepatosteatosis, steatohepatitis, alcoholic hepatitis with liver cell damage, ballooning, degeneration of hepatocytes with infiltration of neutrophils and macrophages, and fibrosis are characteristic pathological findings indicative of hepatitis, release of reactive oxygen species and cytokines, TNF, tissue necrosis factor. These will cause continuous inflammation and damage of the hepatocytes. Hepatic fibrosis. These hepatic stellate cells secrete copious amounts of scar forming extracellular matrix proteins which characterize fibrosis. Fibrosis is transient and reversible. So at this stage reversal can occur, but after this stage liver will convert into cirrhotic form. Hepatic cirrhosis, formation of regenerative nodules of hepatic parenchyma surrounded by fibrous septa that severely compromise the liver's vascular architecture, and so this will result into portal hypertension. Hepatocellular carcinoma. So hepatocytes itself can be converted into these hepatocellular carcinoma. Chronic alcohol consumption interfere with several host anti-tumor mechanisms. So these anti-tumor mechanism will be disturbed, and thereby facilitating hepatocyte proliferation and tumorigenesis. Plus, the damaged hepatic cells, they can cause portal hypertension, and portal hypertension secondly is that there will be varices everywhere where there is a portosystemic shunt. So there will be bleeding, hematemesis, and the secondly. How is alcohol metabolized by the liver? So microsomal ethanol oxidizing system, MEOS, alcohol dehydrogenase, catalyzed reaction, all of these reactions metabolize ethyl alcohol into acetic acid. What is the mechanism of ascites formation in this case? Obstructed lymphatic drainage, decreased ability of the lymphatic system to drain the peritoneal space, increased formation of hepatic and splanchnic lymph, hypoalbuminemia due to liver cirrhosis and liver failure, increased renin-angiotensin system, RAS system, salt and water retention, increased blood volume. The extra fluid will pass from the mesenteric vessels to peritoneal cavity due to increased hydrostatic pressure, increased vascular wall permeability, and there will be ascites. So for ascites you will always give spironolactone. So spironolactone is potassium sparing, and it will cause the what is the cause of confusion in this patient? So hepatic encephalopathy, patient with macrocytic anemia. What could be the cause? Nutrition deficiency, vitamin B12 deficiency with chronic alcoholism plus folate deficiency. How vitamin B12 deficiency causes macrocytic anemia? So vitamin B12 deficiency is important in DNA synthesis. When DNA synthesis is impaired, the cell cycle cannot progress from growth G2 growth to meiosis stage. So this will keep on, the cell will keep on growing. This leads to continuing cell growth without division, which present as macrocytes. If the patient is to go for liver transplant, what will you tell his family? So counseling regarding patient condition, proposed treatment options, outcome of treatment, lifestyle modification, abstinence from alcohol 6 months later, ABO matching, immune suppression. So you have to explain all these things that we are going for transplant. But if after transplant this patient is not stopping the alcohol, then there is no advantage.